Good afternoon, everyone.
Good evening, sir.
Good
Hello,
evening.
hello, Manjul.
Good evening, sir. Good evening, Girish, sir.
Evening.
Good evening, Matthew, sir.
Hello. So, Manjul is there, our first speaker.
First speaker is probably Dr. Nadeem.
Yeah, Nadeem. Nadeem is from Nimans.
Yeah.
He's now has become Nadeem. He has joined Aster now. Nadeem, would you like to share your slides and see whether it's working? Dr. Nadeem,
Yes, sir.
would you like to check your slides?
Yes, sir. Host disabled participant screen sharing it is showing. I think they need to give me the access, sir.
Yeah, I'll just see.
Sir, we had made you a co-host earlier, and then
No problem.
perhaps you rejoined.
Yeah. Because I was not able to hear anything. Now it's
Now
better.
you
I can
can,
hear.
now you can, sir, check your slides.
Is it coming?
Yes, it's coming up. Can be seen.
Yeah, your slides are visible.
Okay, sir.
Okay. Dr. Sam, I think we can start.
Sir, one of our speaker yet to join. Double sir is joining.
Who is yet to join?
Sir is yet to join. Couldn't see.
Manjul is here. This is Nadeem is here. Madam is here. Sachin has not joined, right?
Sometime. Yes, joined sometime before. Called him. He'll join shortly now.
I joined.
Yeah, Sachin has joined. Nadeem, can you stop sharing?
Yes, sir.
Sam, I think you can start introducing the topics, Dr. Sam. Still, also, it's not good.
Good evening, everyone. Myself, Dr. Sam Skaria, consultant neurosurgeon at NSI Hospital, Kochi. I am really honored to serve as coordinator for today's webinar. On behalf of NSI, it's my pleasure to welcome you all to today's webinar on surgical management of growth hormone secreting pituitary adenomas. Growth hormone secreting pituitary adenomas present a unique challenge in neurosurgical practice, not only in achieving complete tumor excision, but also in ensuring long-term hormonal remission and preservation of pituitary function. Today's session will bring together distinguished experts who will share their insight on this topic. And I think this session is going to give us a very practical insight into that. The session will include a series of 4 expert talks, each about 18 to 22 minutes, followed by a panel discussion at the last. We encourage all the participants to actively engage and post their questions in chat box, which can be taken up during the discussions at the last. Before proceeding, I would like to acknowledge and thank the leadership of NSI for their continued support in organizing these academic activities. It's my privilege to invite our esteemed moderators for today's section. First, I would like to invite Dr. Sachin A. Borkar. Professor Sachin A. Borkar is a distinguished leader in the field of neurosurgery, currently serving as a professor in Department of Neurosurgery and Gum Knife at All India Institute of Medical Sciences, New Delhi. A stalwart of NSA, his leadership extends across Neurotrauma Society of India, NSSA, ISPNS, a faculty of AOSPI, ATLS. He currently shapes a global neurosurgical dialogue as editor of several high-impact clinical journals, executive council member and annual CME convener, NSA, executive officer AOSPI in Asia Pacific, vice chair, spine section ACNS, executive board member Asia Pacific Cervical Spine Society. His academic footprint is equally vast with a portfolio of over 170 peer-reviewed publications, 26 books, and 150 invited faculty presentations across. We welcome you, sir, to this webinar and thank you for the moderating session ahead. Now, I would like to invite Dr. Kodisharna. Sir is a professor and head department of neurosurgery, Hillpok Medical College, Chennai, and the convener of webinar committee as well as executive committee of TANS and NSA. He is an active member of several international bodies. It is an honor to introduce Dr. Kodisharan, a pioneer in neurosurgery, with over 2 decades of experience to his credit. As a chair of NSI Webinar Committee, he has been instrumental in driving global neurosurgical education. Welcome, sir, and thank you for being with us today. Finally, I would like to invite Dr. Matthew Abraham. He is currently the head of the department at NSI Hospital. Has been the faculty in Sridhar Institute since 2003, head of the Department of Neurosurgery since 2017 before taking over at NSI Hospital in 2022. His special interest lies in epilepsy, vascular and skull-based neurosurgery, having published more than 90 papers in the subject in peer-reviewed national and international journals. He has been an innovator speaker over 200 national and international conferences and conducted more than 15 operative workshops. Welcome, sir, and thank you for taking the time to be with us in this evening. Now, I request to kindly introduce our today's speakers and panelists. Thank you, sir.
Let me call on Dr. Sachin Borkar to introduce Anand Balasubramanian.
Yeah, it's my proud privilege to introduce Dr. Anand Balasubramanian, who is the principal consultant and head of department at Amrita Hospital, Faridabad. He is known all over India as well as globally for his expertise in neuro-oncology as well as the functional neurosurgery. He has received his advanced training from University of Toronto, and he has led many reputable hospitals in the country like Kokila Bain Hospital in Mumbai and Yashod Hospital in Hyderabad. He is the recipient of the Best Clinician Award by the ISNO way back in 2018, and it's always pleasure to listen to his insight on neuro-oncology. Welcome, Dr. Anand.
Things that Dr. Kodison, that's my delay. I'll introduce Dr. Girish Menon, who is the second panelist. It's a great honor for me to introduce Dr. Girish Menon, senior neurosurgeon. He's also my teacher. He was former professor of neurosurgery, professor and head at Kasturba Medical College, Manipal. He was a professor at Sri Chitra earlier, where he was trained. He said he's working as head of the Department of Neurosurgery at SP Mediford Hospital, and has extensive experience in skull-base neuro-oncology, vascular, epilepsy, and other complex procedures. He's a strong academician and has a strong research background. He's currently the editor of the Neurology India. He has been instrumental in making so many changes in the Neurology India work pattern. I would like to welcome him to be this panelist, to be a panelist in the meeting.
Thank you, Matthew. Thank you. Welcome, all of you.
We have the first. I'd like to call on Dr. Sachin Borkar to introduce Dr. Mohammad Nadeem. He will be the first speaker. He'll be talking on endoscopic anatomy of the cell. Sachin, I think you have to unmute.
Yes. Yeah, it's my proud privilege again to introduce Dr. Mohammad Nadeem, who is a distinguished neurosurgeon trained at NIMHANS, Bangalore. And he holds MCH from NIMHANS and previously served as some professor in the same institute. He is currently working as a consultant neurosurgeon at Aster RV Hospital, Bangalore, and is actively involved in managing complex and high neurosurgical cases. And obviously, his primary area of interest is neuro-oncology. And I welcome you, Dr. Nadeem, for your insights on this very important topic on endoscopic anatomy of the cell.
Yeah. Thank you, sir, for the opportunity. Good evening, everyone. So I will be discussing about the endoscopic anatomy of cella. So the first structure that we encounter during transnasal surgery is the external nose. The external nose is actually a osteocartilaginous structure, which is superiorly contributed by the nasal bones, which unite together at the midline. The lower aspect is predominantly formed by cartilaginous structure, majority of which is contributed by the upper lateral cartilage, and the lower aspect is contributed by the alar cartilage. The septal cartilage, which forms the septum of the nose, also contributes to the external nose in the midline. The rest portion of the external nose, mainly on the lateral aspect, is contributed by the lesser alar cartilage. If we study the nasal cavity, it is actually transversely flattened and it consists of a septum in the midline. We have a roof, floor, and lateral wall. The nasal cavity has an anterior opening which is wider and a posterior opening which is narrower compared to the anterior opening. The anterior opening is also called as the nasal aperture. It is triangular in shape and its superior aspect is formed by the nasal bones. And on either side, we have the frontal process of the maxilla, and floor is contributed by the palatine process of the maxilla. In the midline, we have the anterior nasal spine. The posterior opening of the nasal cavity is also called as choana. It is bounded superior by the body of the sphenoid and inferiorly by the horizontal plate of the palatine bone. And in the midline, we have extension called as the vomer. And on either side, we have the medial pterygoid plate. The same features can be appreciated here in the articulated skull. That is the vomer in the midline. That is the horizontal plate of the palatine bone. And that is the body of the sphenoid. And on either side, we have the medial pterygoid plates. The wall of nasal cavity has a lot of anatomical implications. It is formed by 8 bones, namely the frontal bone, ethmoid bone, inferior turbinate, sphenoid bone, that is the maxillary bone, palatine bone, nasal bone, with some contribution from the lacrimal bone as well. If we see the roof of the nasal cavity, it is predominantly contributed by the nasal bone anteriorly and sphenoid bone posteriorly. And in the midline, we have the ethmoidal bone and mainly the cribriform portion of the ethmoidal bone, which contributes to the roof of the nasal cavity. And it is through this cribriform plate that the optic nerves enter into the nasal cavity. Coming to the floor of the nasal cavity, it is predominantly contributed by the maxilla, and it is the palatine process of the maxilla that is contributing to the anterior portion of the floor of the nasal cavity. Whereas the posterior portion of the nasal cavity floor is contributed by the palatine process of the palate bone. There are 2 types of paranasal air sinuses that we encounter. One is the anterior group consisting of the maxillary, frontal and anterior ethmoidal air cells, and posterior group which is contributed by the posterior ethmoids as well as the sphenoid. This division is based on its drainage, whether it is anterior to basal lamella or posterior to basal lamella. I will be describing the basal lamella later in my topic. One has to be aware of the various pneumatization that take place in these paranasal air sinuses. The maxillary air sinus actually is present at birth and makes its radiological appearance somewhere around 3 to 5 months of age, and it reaches adult age by the end of 15 years. The ethmoidal air cells are also present at birth. They have their radiological appearance at 4 years of age and they reach adult size by 15 years of age. Sphenoid sinus is not present at birth and it makes its radiological appearance at 4 years and it reaches adult size somewhere around 20 years of age. Whereas the frontal sinus is the last sinus to undergo pneumatization, making its radiological appearance around 6 years of age. So the knowledge about this pneumatization is essential before planning transnasal surgeries. So the lateral wall of the nasal cavity in the anterior portion is covered by hair and the skin. It is called as the vestibule. Posterior to it, we have uniform mucosal covering called as the atrium. And there is the first anterior ethmoidal air cell that we come across, which is called as the agar nasi. It is behind this agar nasi is that we find 3 scroll-like structures behind it called as the turbinates. This is the inferior turbinate. As we trace it posteriorly, we will find the opening of eustachian tube. Then above it, we have the middle turbinate and superior turbinate. Each of these turbinates encloses respective meatus within it, which has few important structures. The one important structure that is present underneath the inferior turbinate is the opening of the nasolacrimal duct. So this is the endoscopic view of the left nostril. The first turbinate that we come across is the inferior turbinate. And as we trace it posteriorly, we find the choana. And if you remember, choana is the posterior opening of the cavity. And the lateral aspect, we have the eustachian tube. And medial to it, we have the frozen molar. And underneath the inferior turbinate, we have the opening of nasolacrimal duct. So the next turbinate that we see is the middle turbinate. Middle turbinate is actually part of the ethmoid bone. The ethmoid bone superiorly has crista galli and cribriform plate through which the optic nerve passes into the nasal cavity. Here is the cribriform plate and the crista galli. It articulates all around with the frontal bone. On the lateral aspect, the ethmoid bone is covered by lamina papyracea. It separates the ethmoidal air cells from the orbital cavity, and it covers mainly the middle and the posterior aspects of the ethmoidal air cells, whereas the anterior ethmoidal air cells are covered by lacrimal bone and frontal process of the maxilla. So that is the lamina papyracea, which is actually gateway into the orbit when we are doing transnasal surgeries. And that is a lacrimal bone, which is actually damaged, but it actually covers the anterior ethmoidal air cells along with frontal process of the maxilla. That foramen that you see is the anterior ethmoidal foramen through which the anterior ethmoidal artery enters into the orbit. And that is the posterior ethmoidal foramen transmitting posterior ethmoidal artery. So this is a representation of the model of the middle turbinate of the left nostril. It mainly has three parts. The anterior part is called as is sagittally oriented, as you can see here. And the middle part is the one. This is the anterior part, and that is the middle part, which is called as the basal lamella. As you can see, it is coronally oriented. And the posterior aspect is actually horizontally oriented. The anterior one-third, which is sagittally oriented, actually articulates with the anterior cranial fossa between the middle lamella and the lateral lamella. So here the surgical importance of the sagittally oriented portion of the middle turbinate is that when we are doing turbinectomy, we should be very careful not to go close to the anterior cranial fossa base because it can cause fracture and there can be inadvertent CSF leak. The basal lamella, on the other hand, articulates laterally with the lamina papyracea, which is actually the medial wall of the orbit. The horizontal plate, which is the posterior aspect, also articulates with the lamina papyracea on the lateral aspect. So if we cut open the middle turbinate, the structure that we see is a sickle-shaped structure, which is called as the uncinate process. And posterior to it, we have a constant and a prominent anterior ethmoidal air cell called as the bulla ethmoidalis. So the two-dimensional space between the bulla ethmoidalis and the uncinate process is called as hiatus seminularis. And the three-dimensional space between them is called as infundibulum. That is so wobbing chronalis. So this is the endoscopic view of the structure. This is the middle turbinate, and we can see that it is enclosing the uncinate process. So the first portion is actually vertical portion of the middle turbinate. And then posterior aspect is the horizontal part. And that is the accessory ostium of the maxillary sinus, which is opening into the middle meatus. So in order to see the coronally oriented mid portion of the middle turbinate, we need to open the uncinate process. After that, we find bulla ethmoidalis, which is an anterior ethmoidal air cells. It is after opening this bulla ethmoidal air sinus that we enter into the basal lamella. So if we recall with the structure that I had shown earlier, this is the basal lamella, which has coronal orientation, and that is the horizontal posterior portion of the middle turbinate, and that is the basal lamella. The nasal septum, which is the mid portion of the nasal cavity, consists of three important parts. They are columellar, membrane, as well as septum proper. The initial portion is called as the columellar septum. The posterior part is called as the membranous septum. And the larger portion of the septum is actually the septum proper. This is the perpendicular plate of the ethmoid. That is the vomer. These are the two bones that contribute to the septum proper. Then predominant contribution is from the quadrilateral cartilage, also called as the septal cartilage. And there are a contribution from other bones as well, like the nasal bone, frontal bone, rostrum of the sphenoid, and inferiorly by the maxilla as well as the palatine bone. So blood supply of nasal septum is both by external as well as internal carotid artery. The internal carotid artery supplies mainly via anterior ethmoidal arteries and posterior ethmoidal arteries. And the external carotid artery supplies via maxillary artery through greater palatine artery and spinopalatine artery. The facial artery also contributes through superior labial artery, and all these vessels form a plexus called as the Kasselbach's plexus in the little's area, which is the common area of epistaxis during hypertensive crisis. Of importance is the spinopalatine artery. This is the endoscopic view of the right nostril, and the spinopalatine artery enters into the nasal cavity through the spinopalatine foramen in between the opening of the sphenoid sinus, that is the sphenoid ostium superiorly, and the choana inferiorly. So after coming out, it gives two branches. One is lateral branch called as the spinopalatine artery, which supplies the turbinate. And on the medial aspect, we have the nasopalatine artery. It is this nasopalatine artery that the Haddard flap is based upon. So once the Haddard flap is raised and placed within the choana, we usually do a posterior septostomy to completely visualize the anterior wall of the sphenoid sinus. This is how the anterior wall of the sphenoid sinus would look. That is the sphenoidal crest or the sphenoidal process. And on the either side, we have the sphenoid ostium, giving it a classic owl-eyed appearance. So in order to identify the sphenoid ostium, one can see the choana and trace superiorly. It is usually located few millimeters above the choana. And once the posterior septostomy is done, this is how the anterior wall of the sphenoid sinus would look. That is the sphenoid crest in the superior aspect, and that is the vomer of the sphenoid bone. Usually the vomer is preserved so that we get this midline orientation during transnasal surgeries. So sphenoid sinus is actually an important structure for endonasal surgery. It shows three kinds of pneumatization. One is the cellar type, where the pneumatization extends posterior up to almost the clival recess. And the second variant is called as the pre-cellar type, where the pneumatization extends not beyond the anterior wall of the cellar. And the third one is called as the conchal type, where there is a solid block of bone underneath the cellar. So when we talk about depth of the sphenoid sinus, actually the length between the sphenoid ostium and the anterior wall of the cellar, and usually it is between 12 to 20 mm. Sphenoid ostium show numerous septations within it. Usually we have one major septum and few minor septums within it, and it divides the sphenoid sinus into unequal parts. And of importance is that these septums are usually have a connection towards the carotid. So when drilling or removing this septum, one has to be very careful and be gentle in order to avoid inadvertent injury to the carotid artery. So the sphenoid sinus per se has an anterior wall, a posterior wall, floor, and two lateral walls. So this is the sphenoid bone, and this is the anterior aspect of the sphenoid bone. So anterior wall, we can see the sphenoid process in the superior aspect, and inferiorly we have the vomer. And on either side, we have the sphenoid ostium. This is the ostium of the left side. And as we go superolaterally, we have the sphenoidal concha, which articulates with the ethmoidal bone. That is one half of the sphenoid sinus anterior wall, which is removed to give you an orientation. So once the anterior wall of the sphenoid sinus is opened, this is what we see next. We see superior wall of the sphenoid and posterior wall of the sphenoid with numerous prominences which have great anatomical significance within it. So that is the carotid prominence which corresponds to the carotid artery. Then we have the optic prominence which corresponds to the optic nerve. So superior wall is actually formed by the plenum and and the posterior wall actually corresponds to the clival recess. So there are numerous recesses within this structure, like the tuberculum recess, which corresponds to tuberculum sella on the other side. So in between the carotid and the optic prominence on the medial aspect, we have the medial opticocarotid recess. And on the lateral aspect, we have the lateral opticocarotid recess. And in between the sella and the carotid, we have the caroticocellular recess. So these recesses actually corresponds to structures that are on other side of the cella and gives us an idea or the orientation about structures that we may encounter if we pass through them. So this is the tubercular recess. And if we go few millimeter above and lateral to the tubercular recess, that corresponds to the distal dural ring. And the anterior aspect of the diaphragma sella is attached to at the region of tuberculum recess. So this is the lateral opticocarotid recess, which is present on the lateral aspect between the optic as well as carotid prominence. It actually corresponds to the optic strut on the opposite side. So this is actually the optic strut, which is the bony connection between the sphenoid bone and the anterior clinoid process. It separates the optic canal from the superior orbital fissure. So as we extend and go medially from the opticocarotid recess, it corresponds to the proximal dural ring, and the segment of carotid between them is called as the clinoidal segment. And we know that the medial portion where there is dehiscence of the distal dural ring, it corresponds to the carotid cave. So this portion is called as the optochiasmatic recess, and it corresponds to the optochiasmatic sulcus on the other side. So this is the other side of the sphenoid sinus. That is the optochiasmatic sulcus. That is the tuberculum sella, and that is the planum sphenoidale. So if you see here, the sphenoid sinus is actually thinnest in the region of floor of the sella, which makes transnasal sphenoidal surgeries easier. So an important structure that is present on the lateral aspect of the sphenoid sinus is the carotid artery. As it passes through the carotid sulcus on the lateral aspect of the body of the sphenoid, it forms the carotid prominence, as you can see here. As it passes laterally, it forms prominence within the sphenoid sinus, called as the carotid prominence. So in a well pneumatized sphenoid sinus, we can actually appreciate three portions of this carotid which is present in the sphenoid sinus. One is the retrocellar, which is present posterior to sella. And the other one is infrasella, which is present below it. And anteriorly, we have the precellar. Precellar is usually seen in 98% of the cases, infracellar portion in 80%, and retrocellar in 78%. And the carotids are usually closer at the region of tuberculum sella. So this is how the optic nerve passes through the optic canal, and you can imagine how it is related when we enter into the sphenoid sinus. So as it passes through the optic canal, it forms the optic prominence in the sphenoid sinus. And that region between the carotid as well as the optic on the lateral aspect corresponds to the carotico-optic recess, which leads to the optic strut. So there are other nerves as well that are related on the lateral aspect of the sphenoid sinus during transnasal surgery. The third, fourth, and sixth nerves are actually located lateral to the carotid and are not directly related with the lateral wall of the sphenoid sinus. But however, it is the fifth nerve, and it is the maxillary division of the fifth nerve that is present on the lateral aspect of the sphenoid sinus. So the last aspect of the sphenoid sinus in the anatomy here is the floor of the sphenoid sinus. This is the posterior aspect of the sphenoid bone. And here you can see the Vedian canal, and that is how the Vedian nerve goes into the Vedian canal, and it appears in front of the body of the sphenoid. And here you can see that it is intimately related in the floor of the sphenoid sinus before it goes into the sphenopalatine ganglia. This is a picture taken from the top, and that is the floor that we are seeing. The important structure that you need to see is a petrous ICA, and this Vedian canal actually reaches the petrous ICA. So with this, the endoscopic anatomy of sella is covered. Thank you.
Thank you for an excellent talk. I must admit, Nadeem, you're an excellent teacher, really talented. Our next talk is by Dr. Thawal Shukla. Let me introduce Dr. Thawal. Dr. Thawal is currently working as professor of neurosurgery at NIMHANS, Bangalore. He did his MCH in neurosurgery in 2002. He was after that he joined NIMHANS as associate professor in 2009. His main interests are in endoscopic neurosurgery, pediatric neurosurgery, vascular neurosurgery. He also has a deep interest in research in traumatic brain injury. He has guided many MCH, MPhil, and PhD theses. He has been an investigator for many national and international multinational research projects, most of them related to traumatic brain injury. He has been involved in international level research in traumatic brain injury also. He has been a speaker in more than 100 talks at national and international levels. He has more than 300 publications, and he's a great teacher. And he's particularly good with functioning pituitary adenomas. Over to you, Thawal.
Hello, good afternoon, everybody. Thanks, Matthew, for the introduction. So when it comes to surgery for growth hormone secreting pituitary adenoma, it's not largely different from any other pituitary tumor. And the principles of surgery remain same. And most important is knowing the anatomy, which Nadeem has very covered. So I will just briefly mention how surgery for growth hormone secreting pituitary adenoma is different from that of other pituitary tumors. So I start with this picture. This is a picture of a mountain viewed from Mount Vesuvius. So it is called Monte Sama, which appears like a giant sleeping with a pointed nose. And same is the appearance of a person with acromegaly when he is sleeping on our operation theater table. He looks same like this mountain. So why we need to treat it's not going. Next. Why we need to treat? Is it moving? Are my slides moving?
Not yet.
Why it's not moving? Maybe next time I'm not going to do anything.
Have you put it in play mode?
It's F5. No, it's not. It's not going further. Yeah. Now it's moving, right?
No, it's not.
Now?
Not going yet.
Now, can you see the next slide?
No, it's
we
not.
can't.
Please unshare it and reshare again.
You can stop sharing and then come back again once more.
Can you see the second slide?
Yeah, we can see the second slide.
Okay. Okay, so why do we need to treat the growth hormone secreting pituitary adenomas? If we don't treat, we have already seen in mythology as well as in real life giants, and they become big. The problem is not being big from outside, it is big from inside. They develop visceromegaly, which can be fatal. Next. They not only become big, they become tall as well. Of two girls. So that with very small tumor, the height can increase enormously. Whereas in the other girl, the tumor was very big, but it was germinoma and it destroyed pituitary and caused an hypopituitarism. So
Sir, your
pituitary
slides are not moving actually. We are on the second slide actually.
I am on third now.
Put on a play mode.
Play mode.
Yeah.
It is on play. It's
Left
not
side,
happening.
left side top.
It's not allowing. Oh shit.
It moved. Now one slide moved.
Lag is now. Okay, I'll share the screen. That should be better.
Can you put on that play mode? This is.
It's not moving. Are you able to see next third slide?
Yeah, we are able to see.
Yeah. So it's a rare chronic disease and it is associated with high morbidity and increased mortality when not adequately treated. And the mortality is related to cardiovascular, mainly cardiovascular, sometimes respiratory. And in long term, patients can develop cancers, particularly colon cancers, which can also kill the patient. So main goal of treatment is to relieve mass effect and biochemical remission. Now we have endocrinologist on board who will be telling details about the biochemical remission. But when we started our residency, the goals were like 5 nanogram per ml. Then by the end of our residency, it became 2. And now the Endocrine Society recommends less than 1 nanogram ml random GH and less than 0.5 after glucose and normalized age match IGF-1 levels. So treatment can be done using surgery, radiation, or medicines. So why to do surgery? So this is an example of our small series of gamma knife radiosurgery. Now, what happens with gamma knife radiosurgery? It is quite effective treatment, but it takes a very long time. So long back, we analyzed 15 cases, and at end of 2 years, also you can see the from the mean of 27 growth hormone, it reached up to 4. So considering the remission criteria according to Endocrine Society, we could achieve only one cure. So this is an example like this. There is the residual tumor in the left cavernous sinus. From pre-op GH, it reduced to 34 and it reduced further. And before gamma knife, it was 24. The tumor was big. Tumor has shrunk. Growth hormone has also come down, but it is still far from criteria for cure. However, primary gamma knife radiosurgery can be given for acromegaly in medically high-risk patients and older patients. This is a 77-year lady who had diabetes and on further evaluation was found to have tumor in the sphenoid sinus. It's like an exophytic pituitary adenoma. You can see normal pituitary in the sella and the tumor is exophyting into the sphenoid sinus. She refused surgery considering old age and there were no neurological symptoms. And she was not much bothered about her appearance. So in such case, we can give primary gamma knife radiosurgery. Why not medical treatment? Like medical treatment is quite effective for prolactinoma. It is effective for GH secreting adenoma. But again, with medical treatment, you require lifelong medical treatment. We were part of pasireotide trial. And this is example of one such case where there was a residual tumor. The tumor also shrunk. The growth hormone levels also came down, but it never led to cure. And many patients stopped this treatment because of hyperglycemia and gallstones. Sometimes cabazole is also given for small tumors and modest increase in growth hormone levels. So this is we have given cabergoline for 4 cases. It is useful for mammosomatotroph. Like this is a giant mammosomatotroph who underwent surgical resection because of neuro-ophthalmological problem, and this was a residual tumor near the cavernous sinus on the right side. So cabergoline was given. There was this is pre-cabergoline and post-cabergoline. There was reduction in the size of the tumor, but it still did not result in cure. Though the prolactin levels came down significantly, but growth hormone levels did not come down. So this all indicates that whether you give radiation or you give medicine, none of them result in cure in large number of patients. They all cause reduction over long period of time. And during this long period of time, patient is exposed to excess growth hormone and its side effects. Hence, surgery is the first treatment for such patients. The goal of the surgery should be gross total resection whenever possible for rapid normalization of growth hormones and IGF-1 levels, and at the same time, functional preservation of the normal pituitary gland. If it is visible, it should be preserved. Decompression of the optic apparatus should be done, and histopathology should be obtained, and immunohistochemistry should be done. Like we can find mammosomatotroph on immunohistochemistry. Now we can do receptor analysis like SST2 and 5 receptors. And we have pasireotide, which is the SST5 receptor antagonist. And targeted therapy can be given for the residual tumor if you know the histochemistry from the tumor. Preoperative workup, neuro-ophthalmological testing is done for all tumors, including growth hormone secreting tumors, but particularly for GH, ECG, and echocardiogram are mandatory irrespective of the age, as these patients can have asymptomatic left ventricular hypertrophy, arrhythmias, and cardiomyopathy. All of them can contribute to cardiac morbidity and mortality after surgery. Besides this, patients also have medical comorbidities like diabetes mellitus and hypertension. Like endocrinologists will say, if you don't operate, this will not get controlled. Whereas our anesthesiologists will ask them to be controlled before doing surgery. So there is a trade-off between control before or after surgery, but it has to be done. And one particular problem seen in GH tumors is obstructive sleep apnea. They have everything big, not only the nose, but pharynx, larynx, and palate. And at the end of surgery, particularly transnasal surgery, when you pack the nose, it also causes further edema. And this OSA can worsen after surgery. And OSA will cause carbon dioxide retention, which will cause increased ICP and which predispose to PSF leak. So this has to be kept in mind, like OSA patients may have problem in perioperative management. So though it is obvious from the morphology of the patient is growth hormone secreting pituitary adenoma, still complete pituitary hormonal panel is required. Not only the basal growth hormone, but following glucose test and also IGF-1. Glucose test, if you just do growth hormone, it vary. And we have even seen patients who had a modest increase in growth hormone before surgery, and when do after surgery, paradoxically it increases in though the tumor is removed. There can be fluctuations in the growth hormone levels throughout the day. So it is better to do with glucose suppression, and IGF level are more important. It should be normal or for cure in according to the age and gender. Thyroid function is required because there can be delayed recovery in patients with hypothyroidism. And post-operative respiratory depression and hemostatic abnormalities are also known in patients with thyroid dysfunction. Cortisol is required. Sometimes large tumor can cause hypocortisolism. So there are two schools of thought, like somebody gives perioperative steroid for all patients, whether it is growth hormone secreting or not secreting. Whereas CMC Valor and some other institute also follow steroid sparing protocol, who do not give steroids perioperative for pituitary tumor patients, and only patients with hypocortisolemia or elderly patients perioperative steroids are given. So this is the reason that cortisol also should be known before surgery. Besides that, elevated prolactin is common due to stock effect, but more than a stock effect, if prolactin is elevated, it can indicate somatomemotroph, and that can be treated after surgery with cabergoline. Testosterone is important in males, as many patients with growth hormone secreting adenoma present with impotency, loss of libido. which the history of which may not be elicited before surgery. And after surgery, when growth hormones, everything come down and neuro-ophthalmological symptoms improve, these symptoms come into forefront and patient may blame surgery for hypogonadism. So it's better to do baseline testosterone before surgery to show that patient had low testosterone may require after a surgery as well. And testosterone is not only a sex steroid, it is also an anabolic steroid and may require replacement after surgery if there is low level. MRI we do for all patients, but in pituitary adenoma particularly, it is important to look not only the tumor, but nasal anatomy, as Nadeem told. You have to look nasal anatomy if you're planning for transnasal approach. So in growth hormone excess, there is hypertrophy of turbinates, so which can be troublesome. And you have to mobilize turbinates. Sometimes you have to do turbinectomy. There may not be enough space in the nasal cavity, so you have to do turbinectomy. However, after turbinectomy or mobilization of turbinate, luckily these patients have large sphenoid sinus, and most of them have very well pneumatized sinus. So once you reach sinus, you get abundant space. But to reach sinus in presence of hypertrophic turbinates and mucosa, there can be lot of bleeding. And when it comes to the tumor, you have to look for the extent of the tumor. Among all the extent, the NOS grading, that is extent of invasion of the cavernous sinus, has been found to be most important determinant of growth hormone remissions. So tumors, small tumors are amenable to surgery, but large tumors like this are difficult to operate with single approach and may require multiple approaches. And patients, relatives and patients have to be counseled that big tumors will require more than one approach, not only surgical approach, even medical and radiosurgery. Sometimes plain MRI may not be sufficient to find the cause of the growth hormone excess. This is a case of recurrent acromegaly. She was operated in 2015. She attained remission for 10 years. She had recurrence, and again she was operated. Again, she had remission. So this is an interesting case where growth hormones came down, but IGF-1 never came down. So the initial MRI did not pick up tumor because there were a lot of artifacts due to surgery, due to cavernous sinus enhancement. And when we did PET, we found a small hotspot. So now this is right on the top of the carotid. And third surgery in presence of adhesions would be risky. So this patient is now scheduled for gamma knife radiosurgery. CT scan is required to know for bony anatomy, what all anatomy Nadeem told, because ultimately when you do transnasal surgery, it is removal of bone or preservation of some bones or mobilization of bones or identifying some bones to identify carotid or the tumor. So among all the tumors, the growth hormone secreting pituitary tumors have a high tendency to for bony invasion. Like clival invasion is seen in 20% of the cases with growth hormone secreting tumor, cellular in 50%, sphenoid sinus in 28%. Whereas non-functioning pituitary adenomas tend to invade more supracellular space, whereas the growth hormone secreting adenomas invade bone. So when there is a bone invasion, you have to remove extra bone, not only for excess, but also for cure. And in MRI, when this cavernous sinus invasion, you may have to even resect the medial wall of the cavernous sinus to have biochemical remission. So among all the surgeries, transitional surgery is definitely first line of intervention. Even with large and giant tumor, the tumor which I showed earlier, we did transsphenoidal first. Our success rates are better with transsphenoidal surgery. Obviously, with smaller tumor, success rates are more than for bigger tumors, whereas in giant tumor, biochemical remission is far from reality. So those surgery at the one-time cost of surgery is very expensive, particularly in private hospital when patient does not have insurance, but it's still relatively cheap considering the cost of gamma knife radiosurgery and repeated surveillance required after radiotherapy or radiosurgery and medical treatment where medical treatment is required for lifelong. So surgery is definitely cheaper though the initial cost may be higher. And surgery leads to debulking and better response to medical treatment. It's not only for remission immediately after surgery, but debulking will also lead to decreased tumor load and a better response to reduced surgery as well as to medical treatment. Reoperation is controversial if the tumor could not be removed. With current era of advanced endoscopy, extended endoscopy, neuronavigation, Doppler, and even intraoperative MRI, it is unlikely that you will leave a tumor unknowingly after surgery. Most often, you would have left the tumor because it would not have been accessible, or it would have been invading cavernous sinus, very close or adherent to carotid artery. So in current era, if there is a residual tumor after surgery, you know that surgery had not removed because of risk or because. So in to operate again, you will the same day what you face during, you may not be operate. Case that multi-departmental tumor, yes, resurgery with a separate after doing transfemoral surgery, you can transfer surgery and you may be able to remove some more tumor, may not. Whereas medical treatment before surgery, is it useful or not? In current era of neoadjuvant chemotherapy for other cancers, we give chemotherapy before surgery to shrink the tumor and make it amenable for radical resection. Whether such strategy can be employed for growth hormone secreting pituitary adenoma, we do not have clear evidence whether it can be done. But yes, medical therapy may be given to control the medical comorbidities rather than shrink the tumor and make it amenable for total resection. So predictors of surgical cure are growth hormone levels. Like classically, it is described as 40 or more. If growth hormone levels are 40 nanogram or more, the cure is less likely. And maximum tumor diameter 4 centimeter or more, again 40 millimeter or more, the chance of cure is less likely. And tumor volume and invasion, even in the smaller tumor, but if tumor is invading the cavernous sinus, even with surgery after entering the cavernous sinus, still the cure rate is less. These are the data from our own series. Like our growth hormone levels, pre-operative growth hormone mean are 76. So which you can understand, the growth hormone levels are in so much excess in Indian context. The patients come so late. So the cure rate is not great in any of our setups. So in our own series, we had 110 patients, but we had some follow-up. 10 patients were lost to follow-up, and 89 patients were available. So our cure rate were very only 26%. So somebody may criticize you have very low cure rate. The reason is we stuck to the stringent criteria, that is less than 1 nanogram random or less than 0.4 after glucose tolerance test and normalized IGF-1. Considering all this criteria, the cure rate is not great even in big centers, particularly with large tumors and when patients present with blindness rather than just change in the facial appearance. The cure rates are not going to be that great. So in small tumors like this, where pituitary also can be seen separately and separately, there is no cavernous sinus invasion. And with preservation of pituitary function, you can see the normal pituitary is preserved, pituitary is preserved, and function is preserved, and follow-up outcome is also good, like all skin changes, thick lips, not only the size, but the overall skin pigmentation, skin acne, everything disappears after surgery. So this happens as early as 3 months after surgery, whereas with radio surgery, it can take up to 2 years for these changes to come. So not only small tumor, even if tumor is big, it's not only the size which matters, is the shape and the direction of the tumor growth. Like in this, it is quite conformal tumor, no cavernous sinus invasion, though it appears, but it is going in one direction, only in suprasellar direction without lateral extension. Is another tumor only in suprasellar extension and no lateral extension. So in such cases, biochemical remission can be achieved with preservation of pituitary function. So that's my take-home message. Like surgery should be the first treatment. In smaller tumors, biochemical remission can be achieved. In larger tumors also, it can be achieved provided tumor is in line of your surgery and has not invaded multiple compartments. And in very large tumors, if it is still in cellular supracellular, part of tumor is in cellular supracellular, endoscopic transnasal surgery is preferred, then transcranial surgery. And even if large tumor, though biochemical remission cannot be achieved immediately after surgery, the tumor debulking will help radiation oncologist to give less radiation to the smaller tumor and also to endocrinologist for medical treatment. Thank you.
Thank you, Dr. Thawal, for an excellent talk. You have covered all facets of operative management. Our next talk is on radiosurgery in DH secreting adenomas. The speaker is Dr. Manjul Tripathi. To introduce Dr. Manjul, he's well known in neurosurgery all over the country. He's currently professor in the Department of Neurosurgery at PGI Chandigarh. He's also in charge of radiosurgery and functional neurosurgery services. He's actively involved in several leading international and national neurosurgical bodies. He's currently the WFNS ambassador to the International Stereotactic Radiosurgery Society. Dr. Tripathi is extensively published. He has more than 380 research publications and has played editorial role in many reputed journals like Neurology India and WFNS Journal. His expertise includes gamma knife, radiosurgery, functional neurosurgery, neuro-oncology, and neurotrauma. I invite Manjul to give his talk. Dr. Manjul, you are still muted. You're muted still. Dr. Manjul.
So probably.
Yeah, you're still muted. So you're still muted. You're still muted. Yeah, can you exit? Can you exit and come back or re-enter? I'll ask Navneet to. Okay. Okay.
Am I? Yeah, I think
Yeah,
I'm visible
you're
now.
audible. Perfect.
So, actually, trouble with Zoom, howsoever you have tried during the time of your COVID, it still gives you some this situation sometimes. So, is my screen visible now?
Yeah, you're visible.
Okay. Yeah. If I can just take this sideways, yeah, continue to share. Thank you so much, sir, and extremely sorry for this trouble. This is some technical trouble which I couldn't solve at that point of time. And Dhawal sir practically covered the majority of the part, not only of the surgery, but in a holistic way of radio surgery and the medical management, as he usually always do. So my thoughts would be resonating what he has just spoken. This is aerial view of Venice, which looks like Sela. So, and this is not Khali, this is another police constable from Haryana, whom we have been treating for his gigantism because of a pituitary tumor. So, my screen, can you? Are you able to see my screen moving?
No, not yet. It's not moving.
This is pretty funny. I do not know why is this happening.
I think you can exit and start sharing again.
Opportunity for that. Sir, this is paused by the back end actually. What I'm doing, it has been paused by the back end. I do not know why is it happening. So finally, okay, are my slides visible now, sir? Moving?
Yeah, it's very much visible.
Sorry again. So I'm here in a dual role of a microsurgeon and gamma knife radiosurgeon for this particular disease with no particular financial disclosures. And the radiosurgical experience which I'm going to speak today is actually with my experience with gamma knife radiosurgery. As Dr. Dhaval just told, I always believe that surgery, whether it's a functional or a non-functional pituitary adenoma, whatever it is, the surgery remains the best shot with that particular patient. It provides you multiple advantages, removes the tumor, provides you a pathology so that you can have some evaluation on the pathological markers about this tumor. It gives an immediate decompression. If you are able to remove the tumor completely, you do not need any other medical or radiation therapy. And if we are talking about the acromegaly, the kind of hormonal normalization and the rapidity with which surgery provides you that normalization, no other treatment modality can give you, whether it's medical treatment or radiation therapy or any sort of a radiosurgery. Nothing provides you that good outcome. Over the course of time, our armamentarium has definitely become much better. We are removing successfully from practically every corner of the sella and cavernous sinus. But still, we know that once the tumor is extending into the little part of the ICA, then the chances of residue are significantly high. And in those cases where the tumor is extending beyond ICA, the chances of residue are close to around 30 to 40%. In case of an acromegaly, leaving a residue in that way leads to a chance of a long-term poor hormonal control because then we do not achieve that so-called remission in these patients. So if somebody has a leftover, then we need to first decide when they come after 2 or 3 months with an evaluation, do I really have a residue? Should I be worried about it? And since it hurts the surgeon's ego, if it is a large one, should I remove it again? Or if it is a small one, can I just observe it or I need to some adjuvant treatment? While treating with an there is the role of and guide my patient with which technique I'm going to treat this patient. There have been multiple guidelines and multiple center studies. The problem with acromegaly Cushing is that most of these studies are retrospective studies, and so they do not become better than a level 3 evidence. So, functional adenoma, ISRS, International Stereotactic Radiosurgery Society, they try to publish their guideline. We know that after prolectinoma, acromegaly is the most common problem, and in those cases, we have a dual responsibility. First of the tumor control, second is the biochemical control because they are still actively secreting the growth hormone. And I say that there is a limited literature. Surgical management of acromegaly, as Dr. Dhaval just told, the chances of remission rate are pretty high. If you go with the worldwide literature, with only surgery, and that should be the first and the best shot, your rate 4% in these patients. That means to 50% to 30% of these patients are still having some residue tumor. Now, the biggest fallacy is what is the definition of cure versus control, and there has been no consensus. You have Pituitary Society guidelines, we have Society guidelines. And if you go in the retrospective analysis, the which have been published before 2010, different studies have used different yardsticks to show their results. Some have told about the normal IGF-1, some went with normal GH, less than 1 nanogram per ml. Some show go with the normal GH suppression with an OGTT. And this definition really matters. because on this particular basis, we are going to decide the remission rate with any particular treatment modality. Radiosurgery has a latency period, so the biochemical response is very delayed, complicating the interpretation along with the criteria those particular studies are using. So,
Sir, I think your slides are again
hello,
stuck.
Yeah.
are they moving?
No, slides are not moving, sir.
I'm not getting any control actually over here. So, and your screen sharing is paused, it's showing every time. So,
Sir,
Manjul, why
just
don't
unshare and share
is
the
it
whole
is
desktop,
is it
sir.
okay in this way? Is it okay in this way?
Manjul,
This,
It's moving.
present
this way it is moving, sir.
This,
Yeah, this way it is moving.
this is
Fine.
how Dhaval presented. I think you can present like that, Manjul.
Yes, sir. I'm just going in that way. Okay. So sorry if you missed those ones. So the definition of the cure and control is actually, as I told, it's a very contentious issue in the published literature, and different studies have used different yardsticks. Currently, we are going with the criteria of less than 1 nanogram per ml or less than zero point 0.4 nanogram per ml. But if you go with the literature search with particular treatment modality, it gives a very fractured sort of a verdict over here. Acromegaly with this ISRS guidelines, we had 28 studies. I'm not going with an individual studies because their criteria were very different. These all studies were level 3 studies with more than 75% of studies published were gamma knife radiosurgery based. It had 1335 patients, prior resection in 65 to 100 patients, and the mean marginal dose was around 13 to 35 gray in a single fraction, but the mean dose was 20 gray. They could show that if you go with the radiological tumor growth control, that could be achieved in close to around 94 to 100% patients. And the new neurological visual deficit happened in 0 to 11% patient. That is a significantly big number in the prior series, but if you go with the current series, that number has significantly come down. This all came with a secondary hypopituitarism rate from 10%. That's the mean. 0 to 40% had been the range. Endocrine cure rates could be achieved in 44% at the end of 3 years. But if you follow these patients as to the longer duration of time, over the course of time, the hormonal remission could be achieved in majority of these patients. Like this is the Milan series by Piero Picozzi. It was 57% at 5 years, but it improved to 80% at 10 years by that single session of radiosurgery. Similarly, this is from the University of Virginia, and their remission rate could be achieved in 83% because they used a slightly higher dose to the tune of 25 gray rather than 20 gray. With this 1335 patients, they could identify some predictors of grand remission. Biochemical rate data showed that if pre-radiosurgery GH and IGF-1 levels are less than the 2.25 times of the normal range, then there are high chances that we are going to achieve a remission. Other factors were absence of the cavernous invasion, a clear-cut definition of the tumor, male sex, higher tumor dose, and absence of the suppressive medication, especially the somatostatin receptor ligands. Then the chances of remission are higher. Most recent studies have reported cessation of medication 2 to 3 months before and after the SRS. This is again in a study I was a part of that for SRS for acromegaly. This was under the aegis of IRF. We could achieve a 60% durable duration control. And the factors which we identified, which were influencing the outcome, were serum IGF-1 level prior to SRS, marginal dose close to the tune of 25 gray, and in some cases, whole cellular radiosurgery once we are not able to identify the tumor on the radiology. With this, irrespective of the tumor type, we could achieve an excellent tumor control. Tumor control means radiological volumetric control. The results were slightly better with acromegaly in 97% versus 92% in Cushing and 93% in prolactinoma. And these patients, endocrine remission, once we evaluated, we found that in acromegaly, at the end of 3 years, the remission could be achieved in 44%. It was slightly better in Cushing. In prolactinoma, it was 28% because they had a much stricter criteria which impacted the cure rate, but that has to be the true rate. So I think by the end of 5 years, 50% of these patients universally are able to achieve an endocrine remission if the dose is more than 2 gray. Hypopituitarism in acromegalic patients, it was noted in 17% patients, and mostly these are hypocortisolic and hypothyroid patients after radiosurgery. This is a time-bound phenomena, and usually the hypopituitarism starts appearing by the end of 3 years. In India, we are also getting our own experience with radiosurgery for acromegaly. This is the published literature from India in different centers. So gradually we are improving on that part. Looking at this data, which I have just showed, actually that is a sort of a uniform data which that experience we are able to see across the world because we are using the same technique, uniformly 23 to 25 grade dose now, and the tumors are relatively smaller and in the cavernous sinus. So acromegaly is a controversial topic because it needs a multidisciplinary approach. He's the endocrinologist at my place. Dr. Sandeep operates on Sella. I give radiosurgery to these patients. And there are many times there are confusions and controversies here. The main confusion is whether we should wait after surgery for to give the radiosurgery as an proactive treatment or we should give it in a delayed fashion. Had it been a non-functional pituitary adenoma, I'm never proactive with a early radiosurgery in those patients when I see at a 3 months post-operative MRI a residual tumor. But in cases of acromegaly, if I see a tumor and the patient's hormonal levels are still high, he has not achieved the remission, then probably we have not served the purpose, and that hormone level is not going to decrease on its own. So in those cases, it's always better to hit them early. Hitting them early helps in getting hormonal level normalized in next 4 to 5 years. So the delay you make, it becomes further more difficult. And during the delay, there are chances that the tumor may increase in volume as well. If it increases in volume further, the chances of hypopituitarism further increases because in those times, there is an unnecessary radiation exposure to the normal brain and normal pituitary and the pituitary stalk. As far as literature is concerned, there is no consensus if it can be used as a second line or third line treatment because many people believe that if there is a small residue, hormonal levels are low but still not at the remission level. Let's try with the cabergoline and our somatostatin analogs or paracetamol. But medical treatment do not provide you a long-term relief, and you need to continue with them for practically the rest of the life of the patient. And this is not the way to go because these drugs, especially the cabergoline, they are not effective in more than 15% patient. Pegvisomant is pretty costly. So in our Indian scenario, we need to look at that cost effectiveness and the practical applicability of these medical management as well. So in my personal opinion, I always like to go with an early radiosurgery for a residual acromegaly. Whether we should go with a high dose versus a low dose. The definition of higher dose is more than 25 gray. Conventionally, the typical marginal dose is 20 to 25 gray. In EMHANS, we have been practicing 20 to 25. In PGI, we have been regularly doing 24 to 25 gray because the dose prescribed is going to have an impact. If you go with a higher dose, yes, there are chances of other hypopituitarism to the tune of close to around 25 to 40% patients. With these sophisticated gamma knife machines, when there you have a sharp dose fall-off, the chances of hypopituitarism are slightly better in comparison to the Linac-based machines, but still there is a risk. When should we stop the medical treatment before giving SRS? Again, the literature is not very clear, but the conventional wisdom shows that if you stop them by around 3 months before the radiosurgery, the results are going to be better. Because these SRLs have a potentially radioprotective effect. They reduce the tumor vascularity, they make them firm, and that's where the radiosurgical effect and the impact is not that good as we give after waiting for around 3 months. So in my practice, I wait for 3 months before giving radiosurgery, and I restart the drugs so that till the time the radiosurgery has its effect, the patient's hormonal levels should be near normal. So I wait for close to around 15 days after the radiosurgery. One of the major controversies or one of the major problems with the SRS is that it has a latency period. Yes, it has a latency period. And if you follow patients of acromegaly and Cushing, you probably need around 5 to 8 years to declare them in the remission phase. But this is slightly better in comparison to the other radiation therapies where they take further longer time for the hormonal remission, and usually comes because of the hypopituitarism. Hypopituitarism is an acceptable risk in my opinion. Many of these patients, since they have already undergone surgery, they are already majority of them on hormonal replacement therapy, especially for cortisol and thyroid. So it might be a debatable issue whether hypopituitarism or a major long-term morbidity, but I think looking at the aims in these patients, uh, if these patients need some hormonal replacement for the rest of their life, we need to give it them so that the hormonal remission and these all can be balanced. There is definitely a radiobiological uncertainty in the GS secreting adenomas because so far we have no answer why do some tumors respond quickly while others do not. There is no proliferation index. There are beta catenin and other pathological ligands which are being evaluated. SSTR subtype correlation, people have tried to find out. At PGI, we have tried to find out these all parameters, but they didn't give any conclusive evidence which we can use as a predictive biomarker in these patients. This is actually a further debatable concept whether we need to go with a biological radiosurgery versus anatomical radiosurgery. Like in this patient, this is a recurrent case who refused surgery because of the medical comorbidities after the first surgery. And now you need to go with the whole cellular radiosurgery. We have a concept which most of these micro neurosurgeons and endoscopic neurosurgeons now believe that the medial wall of the cavernous sinus had some microscopic deposit. So even after the surgery, once you think that you have sufficiently removed the tumor, the patient's growth hormone and IGF-1 level is not coming down to that much extent. That's because of those microscopic deposits. They're not visible on the radios, on the radiology. So if you are aiming for that aggressive approach, you need to go with the whole cellular radiosurgery. But yes, in that case, there are high chances of panhypopituitarism and the optic neuropathy. In the today's time, I do not find any role of radiotherapy until unless the tumor is so large that it is engulfing the optic apparatus and you cannot deliver a single session high dose. Gamma knife and other sophisticated craniocentric SRS techniques have become much better than RT in terms of the tumor control, hormonal remission, speed of remission, and overall complication profile. So I'm not a fan of whole cellular radiosurgery. I only go there once the tumor is relatively large and I'm not able to see the normal pituitary from the tumor separately. Whole cellular radiosurgery usually makes the sense once there is an MRI negative but biochemically active disease, diffuse cavernous sinus infiltration, and the resource limited settings. In young patients, patients with a clearly defined residual margins with a relatively normal pituitary function and the tumor abetting the optic apparatus, I would only go with the tumor-centric radiosurgery. Now, there has been debate on upfront radiosurgery with these patients of acromegaly and Cushing's without operating on them. Head-to-head comparison has been done. This is published by Jishin P. Shulog, and they have found that there has been no difference in the tumor control, endocrine control, the morbidity in these patients. These patients were relatively smaller size tumors. So the speed of remission was slightly lower in comparison to that patients who have already undergone the surgery. I'm not a fan of these sorts of techniques until unless the patient is medically comorbid and refuses the surgery altogether. This is one of the patient in whom the residue was in the cavernous sinus. It was pretty close to the optic apparatus, but we could treat it in two fractions with a 15 grain one fraction with a higher dose, sparing the optic apparatus. The dose fall off is so sharp that we are mostly able to preserve the optic apparatus from the 8th grade radiation exposure. So the chances of radiation-induced optic neuropathy are actually an exception these days. And if you are not able to preserve that optic apparatus in a single fraction, then it's better to go with the hypofractionated regimes. We have frameless gamma knife radiosurgery, so you do not need to keep the frame on the patient's head. You can treat them in 3 fractions to 5 fractions, and it deposits the required amount of the radiation in these patients while sparing the surrounding optic apparatus. So your safety and efficacy profile is matched. So this is the most robust published guideline. They also advocate stopping the anti-secretory medication 4 to 12 weeks. be lacking somewhere in the long-term response as these keep having these hormone levels in the next 5 to 8 years. So there is no immediate cure either with radiology or with radiation therapy, and the surgery still remains the better. There might be complications like, as I already told, there might be problems with the trigeminal neuropathy, especially if the tumor is extending into the cavernous sinus. Luckily, I haven't found any secondary malignancy so far. This has been a study in which we evaluated around 20 to 54 patients with 15 years probability. When the tumor was extending into the cavernous sinus and we gave such a high dose, there was no new tumor, carotid stenosis, and stroke after hysterectomy radiosurgery for pituitary tumor in these patients, published in 2024. Even in the pediatric patients, these resistant patients we have treated, SRS response had been similar to the adult counterpart, but with a slightly higher chances of the hormone deficiency. So I would say that radiosurgery is highly effective in long-term tumor control. As far as the tumor volumetric control is concerned, it's highly effective. You will get more than 93-94% in these patients, whether it's a function or non-function. It's an extremely effective approach in cavernous sinus residue and recurrences. Accessible in current time because of your such advanced radiology with the target location. Endocrine outcome is still some challenging. It's very safe risk of radiation-induced necrosis. That's my team with which I work with radiosurgery here in BGH. We always see patient information booklet because these patients are very fragile psychologically as well. So you need to tackle them very gently, and I always try to teach them about their disease, and that really helps them in the acceptance of the outcome of these patients. Thank you so much.
Thank you, Manjul, for an elaborate, excellent talk. And now let me invite Dr. Sachin Borkar to introduce Dr. Pramila.
Yeah, thank you so much. It's my pleasure to invite Dr. Pramila Kalra, who is an endocrinologist. She's the professor and senior consultant of endocrinology at Ramaya Institute, Bangalore, and she was trained in endocrinology from SGPG Lucknow. A lot of scientific publications and active participation in various meetings, and she is actively involved in academic leadership as well as serving in various professional societies of endocrinology as well as the journals on the editorial board of the journals of endocrinology like Thyroid Research, and she is the president-elect of the Indian Thyroid Society. So let's hear from Dr. Pramila about the endocrine management of these cases. Welcome.
Yeah, thanks. Thanks, and good evening, everyone. And thanks, NSI, for inviting me for this talk. It's a pleasure to be with this group, and it's a lot of learning for me as well. And when we are talking about growth hormone secreting tumors, I know it's mainly the neurosurgical and the radiosurgery part, which is important, and very important. So I'll be discussing about a little bit about how cutoffs we take, and then also how do we do the perioperative management, and then what are the medical options which we use, because we know that as we were speaking about and as we saw all the cases, we know that even in spite of surgical approach, most of the patients do have residual disease and they need some form of medical management. Even when they go for gamma knife or other radiotherapy, they do need medical management for a longer period because these therapies also take time to work. So I hope my slides are visible, right? Yeah. So we know that when a patient of acromegaly is averagely diagnosed, it's almost a delay of 10 years. And it's also in our country. Many a times we see patients who have been having the uncontrolled diabetes, uncontrolled hypertension, osteoarthritis, and they wouldn't have been picked up. Even they would have gone to so many doctors and they are not diagnosed as acromegaly. So there's an average delay of 10 years, but in our country, it's even higher. It's even higher. But now, thanks to a lot of information, many patients are themselves coming and saying that my face is changing and I think I need to check the growth hormone. In the last 2-3 years, I had few patients who themselves diagnosed and were young patients, and they said that because my face is changing, I read on the net that there is something like growth hormone which might be high, and they the time. So that's a big change we have seen. Now we know that why this is an important disease, because we know that if left untreated, the commonest cause of mortality, obviously in patients with acromegaly, is cardiovascular disease. To multitude of problems. The patients don't just have the coarsening of the features, but they'll land up with cardiovascular disease. They land up with dysglycemia, hyperglycemia, diabetes, which is grossly uncontrolled in many cases, osteoarthritis, uncontrolled hypertension, and many more features. This is how different departments may be involved. So it's a multidisciplinary care. The patient may not just come to the endocrinologist, they may go to dentist also because they may have teeth malocclusion. They may go to orthopedician for the joint pains. They may go to gynecologist as well sometimes because PCOS can be one of the part of the patients presenting with acromegaly. They may go with infertility as well sometimes. They may have colon polyps for which they may go first time to the gastroenterologist. They may have visual issues for which they may first land up with the ophthalmologist. And we know that many a times the pituitary tumors are actually diagnosed by the ophthalmologist because the patient would have gone to them for their visual problems. And headache and all, they might go to the neurologist and they might also go to the psychiatrist. Now, when we are talking about the diagnosis, we know that if we have a patient who has the typical signs and symptoms, like by the time we actually see the patient, they'll have most of it. But many times, if you have a very, like you might have a doubt in some patients, but most of the times we don't have much of a doubt in the diagnosis. So we have to go ahead with the IGF level. And if it is more than 1.3 times the upper limit of normal for that particular age, it confirms. We can also do the random growth hormone measurement, which can be done after the overnight fast. It's basically not compulsorily needed because once you have diagnosed the IGF-1 to be 1.3 times the upper limit of normal with the typical signs and symptoms of acromegaly, you actually confirm and proceed ahead with the imaging. But if you want to prognosticate, you can do a random growth hormone also. We can do a OGTT, which can also be done in case you're not getting the correct results, or in some of the patients who are sick, malnourished, where IGF-1 is not giving you the correct picture and you strongly suspect acromegaly. Now, if we have to do a OGTT, we have to do the tests after glucose, 75 grams of fasting, and then growth hormone at 30, 60, 90, and 120. And we know that there are now with the newer assays, the cutoffs are even lower. Like previously, we used to say only 1, but now we know that even with a BMI of less than 25, if the growth hormone added should be less than 0.4 to say that there's no acromegaly, and less than 0.2 for BMI, about 25 can be considered as the NADIR which should be there. But we know that 1 is the cutoff which we take, but 0.4 and 0.2 are the newer ones. And we also know that it should be performed only if the glucose values are well controlled, because there may be some changes in the value of the growth hormone if the patient has uncontrolled diabetes. Sometimes we do see a paradoxical response to the growth hormone, to the oral glucose intake, and that may be attributed to the ectopic expression of the GIP receptor in the somatotropic adenoma cell. This is more for a prognostication rather than actually for the diagnosis. But if the patient has this paradoxical GH response even after surgery, it definitely suggests a residual disease. Now, when we diagnose a patient, we have done the imaging and we are going to proceed ahead with the surgery. I'll be talking about the medical management, but before we go ahead with the medical management, just a little bit about how to prepare the patient for surgery. Now, this is a very controversial thing because we were discussing that all the patients don't need actually perioperative steroids. But we have to remember that in our country, the patients are getting operated at different places in different departments, and there may not be always the full team available for monitoring. And many times it happens that the perioperative steroids are not given because the pre-op cortisol levels were normal, but the patient would have got post-op cortisol deficiency and might land up with hypotension and other problems. So that's why it's like most of the setups, we prefer to give the perioperative steroid coverage and then later on check the axis and then see if it needs to be continued. This is just a safeguard, but we can understand in the best of the centers, if everything is supervised, then we can not give a perioperative coverage in case the pre-op cortisol levels are normal. So what we practice in our center, we give it because we might not get the immediate information about the cortisol or the cortisol values, and the patients might land up in trouble. So to avoid that, we give a perioperative steroid coverage. It can be given in 2 ways. Either we can give it before sending to the OT a stat dose of hydrocortisone, and then we can give 8-hourly 50 mg, or we can give it as an infusion. In our center, we give it as an infusion where we put 150 mg in 48 ml normal saline and we give it over a period of 24 hours at 2 ml per hour. And then on the day 1, we reduce the dose to 25 mg, and then we reduce further, seeing the condition of the patient. If the patient is deteriorated or something, we might not be able to reduce, but if most of the time the patients do well, we can taper to the maintenance dose. And then later on, post-op, we can always check the cortisol axis and then decide if the patient actually needs to continue the steroids. If the patient's pre-op values are normal, then also if you give the peri-op coverage, you can check the levels after the patient's surgery is done and the patient has become all right. You can check if the levels are above 16. It mostly reflects normal levels and you need not continue. But if the levels are between 3.6 to 9, these patients will need the hydrocort to be continued till we definitively check the axis. Or if it is between 9 to 16 also, we should give a stress dose advice, because these patients may be borderline cortisol deficient. Only after 6 weeks, when we reassess the axis, we get the true picture. Post-op DI is another thing which we need to monitor, and we know that we have to see that if the patient has a urine output in adults more than 250 ml per hour for 2 consecutive hours, and these patients have also a normal or a high serum sodium, and the urine osmolality has gone below 300, then we should suspect that this is suggestive of DI. And we also can do a specific gravity. Sometimes the centers don't have osmolality available, so they can just do a specific gravity, and a value of less than 1.005 suggests the low urine osmolality and can be suggestive of DI with the above picture in mind. Also, if the urine output in thin adults is less, like 200 ml, or like if their urine output is less than 200, they may still have DI. So sometimes in thin adults, we should not just go with 250 cutoff, and they may have even less than 200 ml per hour, but still they may be having DI. So we can use a weight-based criteria, that is 2 ml per kg per hour or more than 50 ml per kg per day would be one of the accurate ways to define polyuria in thin patients. Thyroid hormone, we always check all the axes before, but if the patient has been normal and euthyroid, we can check the free T4 levels by 5th or 7th day of surgery. If the levels are low, we can start. But if in case they are normal, then we can reassess again at 6 weeks, and then we can decide if the patient is absolutely normal. The gonadotroph axis is not an emergency, should not be checked immediately after. We can wait, and we may get wrong reports for the testosterone. So we wait for 6 weeks and check it at the OPD visit, and patients come and then decide. If pre-op they were documented to be low, then we can continue. Now we have all university agreed, and we all know that the guidelines are available. The surgery is the first treatment option. And we know that the surgical cure rates may vary, but may vary from 50 to 60%. And we know that this opens up the Pandora of the medical therapy. So first question, which I would like to just tell, that the thing is that it's not that medical therapy is just post-op. Medical therapy may be needed pre-op also in some cases. Like if a patient has severe OSA, like Dr. Dhaval was pointing out, there can be poor surgical outcomes. And this is a very common problem. Sometimes we see our patients have very severe OSA. That is one of the reasons where we might give medical therapy pre-op. Or there are some controversial places where there are invasive macroadenomas without compression on the vital structures. But most of the times, if it's severe acromegaly with high surgical risk, that's one of the indications where we give medical therapy before surgery. And we also know that there may be also some indications where the patients may definitely require medical therapy, like the patient is having a high anesthetist risk. Sometimes the patient might refuse surgery. There may be patients, we have few patients who have refused because of they have refused because of the age factor most of the times, or comorbidities. That's a very small number, but that's one area where it can be offered before the surgery. Tumors which are invading the cavernous sinus without compressing the optic asthma, when significant debulking is not feasible, or the McCune-Albright syndrome cases where the absence of tumor is there, or difficult surgery due to fibrous dysplasia. Those are some rare case scenarios, or as a bridge till the efficacy of radiotherapy is established. Now, post-op, how do we check? IGF-1 should be measured at 12 weeks after the surgery to definitely say the biochemical remission, but we can do growth hormone assessment on day 1 to 14 at any time, and we can compare it with a pre-op level, and that at least we can get the idea about how much is the patient's remission possibility, and we can do OGTT also to get a further idea. We know that 50% of the patients will get biochemical control after the surgical treatment, 50 to 60%, but many of them may require the post-op medical therapy as well. So we know that we have to see that if the growth hormone levels should be less than 1 at least, But we know with the ultra-sensitive, now we say the levels of 0.4 is recommended. And also if the patient has an adenoma, which is persisting after surgery, or really if the patient has a post-op surgical biochemical control, then we should follow these patients for at least 5 years, and then we have to see whether these patients need any medical management. Now, we also know that post-op imaging assessment is just not the criteria, because sometimes we just get a thing from the neurosurgeon, post-op, they can't see any tumor, even if the IGF-1 is high, but that's not the criteria to define clinical remission, because we know that sometimes there may be very small lesions which we might not pick up. And we know that the first follow-up MRI is recommended to be performed no sooner than 3 months after the surgery, because we need to have the definite idea about what's happening for the gel foam and the adipose tissue packing, which is done. Regular MRI follow-up is not needed for all patients, but we have to see on the basis of biochemical parameters and what are we trying to monitor. So some IGF-1 levels, if we want to measure earlier than 12 weeks, we can measure 6 weeks and we can have an idea about the remission. But if a patient has a level which is higher, even at 6 weeks, we don't need to worry. We can still wait for 3 months, that is 12 weeks, and then decide to start the medical management. Now we have different lines of medical management. So we have the somatostatin receptor ligands, that is the octreotide LAR, which we commonly use in our center. We were a part of the pasireotide trial for around 8 to 10 years. So we have a lot of experience with pasireotide as well. Dopamine agonists are being used in patients where the IGF-1 levels are not so high. And pegvisomant, we don't have it available with us, but that's also one of the options which can be used. So we know that it is the therapy for the patients who are not cured by surgery or is complicated because of some reason, then we can use it as a first line, or we can use it pre-op short period for some reasons where the patient has a very high anesthetic risk, like very severe OSA, and those are the high risk cases. Now we have these three options which are available, and we know that somatostatin receptor agonists, these are the first line medical management which we have available for our patients to be used for as a medical management. Now we know that we have oral ligands also coming up, and pegvisomant we can use if glucose metabolism is impaired, and we are not much concerned about the adenoma size. But we know that it's not available in our country at the moment. But cabergoline also can be used if we have a mild elevation less than 2 times the upper limit of normal for IGF-1. Now, there are some few histopathological changes which we should try to see to decide that which patient is a better candidate for surgery. For medical therapy, and which patient will get a good response to medical therapy. So we can see whether the adenoma is densely granulated or sparsely granulated. That's one of the ways to decide, because we know that that can at least help us to understand like which patient will respond better. Also, we can do the subtype immunostaining if available, but many times we have seen that we don't get those results. Genetic variants, we are not doing for everybody and not recommended also, but if you have a family history of multiple endocrine neoplasia, then or the patient less than 18 years, there all it is recommended. So this is one of the very good slides to show that what are the predictors of the resistance. So if you have a patient who is vastly granulated, one who is younger, who is showing a high intense T2 on MRI, has a high growth hormone at baseline, has a high miRNA, has a negative acute test with octreotide, high Ki67, these are all the patients who may not show a good response. And if you have these, and there are other low E categorin some people are doing, some categorin some people are doing, but it's not the thing which everybody is doing at the moment. So low AIP and low E categorin are not the things which being done routinely. But routinely done is the sparsely granulated hyperintensity T2 on MRI, high growth hormone levels we can see. We can also see the acute test with octreotide short acting and see how the patient has responded. And paradox increase in the growth hormone levels during the OGTT, more than 20% growth hormone increase, also tells that this patient will have a good response to the somatostatin receptor ligand treatment. There are some other less responders like men, and the patients who have hyperinsulinemia sometimes may have an upregulation of the hepatic growth hormone receptors, and which can increase the IGF-1 synthesis, and these patients may respond less as well. So a younger patient, sparsely granulated with a high Ki67, mostly may have some resistance. Now, when we have to monitor, what do we monitor? We monitor the IGF. So IGF should be measured after the first 3 injections, not after the first injection. And then we have to decide when to measure depending on the rate of the IGF-1 reduction. Like suppose you have given 20 mg and now your patient hasn't got the target and you have increased it to 30 mg, then you can measure it again after 3 months. But if you haven't increased it and you have reached your IGF-1 target, then you can maybe measure it later, maybe 6 months or a year down the lane. You don't need to measure it every 3 months. Now, pasireotide is another option which has high affinity for the SST5. It has greater efficacy than octreotide in treatment patients. That is, it has an efficacy of 31% versus 19% shown in studies. And we know that control rates of up to 50% have been seen in those patients who have not responded to octreotide. Now we know that the only problem is that there is an impact of glucose metabolism which happens. So when we did the trial with pasireotide, we found that many of our patients had hyperglycemia. And that was a problem, especially those patients who had prior hyperglycemia had even more severe hyperglycemia. But the rest of the things were much better. The response and the control was much better, especially in those patients who were resistant. And the occurrence of hyperglycemia is lesser if the patient is younger, and those who have normal glucose tolerance at baseline, or those who don't have hypertension or dyslipidemia at baseline. So this was our study, which was published, which we were part of the trial, which was published, where we did it in Cushing's as well. And then we found out that the anti-hyperglycemic medication may be needed in those patients who are on pasireotide, and most of them do well with incretin therapy, DPP-4 inhibitors, and metformin. And metformin was found to be quite useful. Now, pegvisomant, though it is not available, but it is available internationally. It is growth hormone receptor antagonist. It has a very high biochemical efficacy, and this normalizes IGF-1 in approximately 90% of the patients. Can be used as a monotherapy or with somatostatin receptor ligands or with cabergoline. The injection site reactions can happen in some patients. Elevation of the liver enzyme could be one. But if the tumor volume is a concern, then this is not the best therapy. And we also know that it is used as a dose of 10 milligram per day in combination with cabergoline, which can be escalated up to 3.5 milligrams per week. And they found the IGF-1 normalization in around 68% of the patients. After cabergoline was withdrawn, they found the percentage was reduced to 26%. We know that cabergoline is one of the commonly used drugs by us not for the reason that's the best drug, but for the reason that many of our patients don't afford octreotide. And we might end up using cabergoline even for patients who have a IGF-1 even more than 2 times the upper limit of normal. But we know that it is a milder drug. It won't help in those patients who have a very high IGF-1. Their octreotide is the treatment of choice. But if you have IGF-1 which is less than 2 times the upper limit of normal, this can be used, and you can elevate the dose with the serial monitoring of IGF-1 levels, and you can see the response in around 30 to 40% of the cases. Radiotherapy, I'll not go into the detail because it has already been told. Now, what are the unmet needs? We all discussed about octreotide. We know that we have cabergoline, which is for milder cases. We have the pasireotide also available, but we know that still the patients are not best controlled. So we know that there are some still unmet needs. There are some tolerability issues, a lot of factors in our country. Cost is also a factor. So we have also oral octreotide, which has been recently approved, and it is it has an entry coating which prevents its degradation by the gastric enzyme. Its T-half is 6 to 8 hours. The dose is twice a day, and food intake actually decreases the absorption. So it has to be taken 1 hour before meal or 2 hours after the meal. And we also know that this has been found to be helpful. And oral octreotide is one of the it's one of the treatment options which has been available. Now, paltusotine is another option which has been used. We have been part of these trials as well. This is an oral non-peptide molecule, and absorption is definitely limited again when it is taken with food. So again, it has to be taken 1 hour before a meal. It is again a selective agonist of SST2 without stimulating the SST5. So only problem is we get a lot of GI symptoms. In our trials, what we did, we found that patients had a lot of GI symptoms. And it is T-half is around 22 to 34 hours. So it is a once daily dosing. Dose ranges from 20 to 60. We start with 20 and then we see the levels and then we increase the dose over a period of time to 60 if the patients tolerate it well. And around 40 to 42% of the patients have been found to achieve the IGF-1 level normalization with this. So this is also one of the things coming up. And this is also being shown to be useful. Now, subQ depot is also available, octreotide subQ depot. this is being studied at the moment, and this is again a depot technology, and this is a subcute administration, which is a monthly subcute. So we have now the octreotide depot, which is the injectable intramuscular. Now this is a subcute depot preparation which is coming up, and it is stable at room temperature. And the best thing is it can be taken as a self-injection with a ready-to-use pen. So this is the next thing which is coming up at the moment. Paltusotine, I already told you, it is one of the molecules which is being studied at the moment, and it has been found to be useful. So if you see the drugs in development, we have the lanreotide, we have the Debio, which is an intramuscular injection, which mainly targets the SST2. We have other growth hormone receptor antagonist coming up, and the newest is we have monoclonal antibody against the growth hormone, which is in the preclinical stage at the moment. Precision medicine is another thing, because as we discussed, there are not all the responders. We know younger age, male gender, maybe poor responders, sparsely granulated, all these things may be the things which might judge the response, and we may have some genetic changes. So there are precision medicines which are being tried, where they are trying to see that what best predicts, how do we decide on the prediction of the medical therapy in a particular patient, that which will work the best for the patient. And we know that higher levels of growth hormone and IGF-1 in a pre-op in the patients when we are starting medical therapy have been found to have been associated with poor response. So we know that there are some microRNAs which are being studied, and the response to the therapy and the medical management may be modulated by the microRNAs. There are some other factors which have been studied, but some of these, like people have tried to see the filament A, beta arrestins, the GSP oncogene, but these are all in the research phase. It's not that we are doing it routinely for all the patients. Routinely, as I told you, what histopathology we get, what ISCs we get, we can do. But most of the time, these are not being routinely done, but this is how the newer things are coming up. And because all these biomarkers have a low predictive power, so we don't have a very clear-cut idea all from the guidelines that what would be the best. So that's why we know that patients may have different sets of response to the medical therapy. But at the moment, what we have available with us is definitely octreotide, which we are offering to a majority of our patients. AI is another thing. Machine learning models have been evaluated where they have tried to see the age, gender, pre-treatment growth hormone levels, the SST2 and the SST5, and the granulation pattern. So these are the things which have been used in AI, which are more predictive, and they have found them to be quite accurate, 86% versus a 55% accuracy. So we know that the treatment of acromegaly, first line is surgery, and it's contraindicated for some reason. After that, might have to go for a medical management, because many patients don't get the full remission. And we know that even if we go for gamma knife radiosurgery or radiotherapy options, we still need time for them to work. Patients may take a lot of time. In our paclitaxel trials, we had a lot of these patients who had undergone gamma knife surgery, and they were put on paclitaxel, and over a period of 4-5 years, when they actually achieved the remission, those patients continued the paclitaxel and they did well. So these patients do the best when given medical management after the gamma knife radiosurgery, because then only we are reducing the bad or the deleterious effect of the high growth hormone on the body. Pegmisoman can be first line in selected cases, but in our country, we have octreotide available, long-acting preparation, which we use. Mild cases where the IGF-1 is less than 2 times the upper limit of normal, we can use it. Oral octreotide has been recently FDA approved for the use as a medical management option. We have also data on paclitaxel, pegmisoman, and or the other combination therapies in patients who do not achieve the biochemical control with a single management. And we know that improving the quality of life and testing them for other complications, because many of them may continue to have permanent diabetes. Many of them may have other comorbidities like hypertension. There's a lot of impact on the quality of life. There's a lot of data which has come up on the quality of life in these patients, because many times there are a lot of cosmetic issues also which come into picture. Patients who are planning for pregnancy, that's another group in itself, because we need to give them the gonadotropin therapy after they get the surgery done. We had recently a lady who had acromegaly, and she was on octreotide, and then because her levels were better, she stopped the octreotide, and actually during the time her levels went up, but she conceived. And she had actually got a successful pregnancy now, and her child is now 6 months. So there are cases where they do well, but there are cases where there may be problems. So that's why we have to decide on individual patient and decide on what is the best management plan for that particular patient. But the subcutaneous octreotide, which is coming up, And the newer medications, including the monoclonal antibody against the growth hormone, which is being studied, could be game changers in the future. And therapeutic approaches definitely have to be decided as per to achieve optimum outcomes. Like if you have a patient who has uncontrolled diabetes, obviously peptide may not be the best choice for that patient. That patient will be better with octreotide. But as of now, peptide is approved by DCGI, but it's not being available in our country for reasons of because it's a costly drug. So the company was not very keen on marketing it in our country. So these are the ways we can manage medically these patients. And I think that is how it has to be a multidisciplinary approach rather than a single center or single department approach.
Thank you, Dr. Tamila, for an elaborate, excellent talk. Now it's time for the panelists to give their expert opinion. Let me invite Dr. Girish Menon to give his comments on the comments about the field.
Thank you, Matthew, Kodishwaran, and Sachin. And of course, compliments to all the three speakers for a very lucid presentation. In fact, the entire spectrum of this problem has been covered. But as all of them have repeatedly pointed out, this is a very challenging problem, and as the statistics would show, even in the best of results, what you're looking at is at 60 to 70% of cure. Now, when we talk about cure, there are three aspects of cure. You have a clinical cure, you have a radiological cure, and you have a biochemical cure. Now, biochemical cure, of course, there is some clarity on what defines biochemical cure. Although, as Dhaval was pointing out, that has been evolving. Like when we studied, when we were residents, the GH nadir was even 5 after a glucose challenge. And IGF, so IGF levels of more than 1.3 compared to the corresponding age and sex. Those new developments, and so of course there is some clarity if you look at the 14th consensus statement as published in the journal. So there is some clarity on biochemical cure, but radiological cure, as Manjul was pointing out, a clean scan does not translate into a clean image, because as has been pointed out, in the lateral walls of the cella, there might be microscopic residues which are not picked up on scan. So a clean post-op scan does not necessarily mean total eradication of tumor. And the third aspect, which is totally no clarity, is clinical cure. All of us would have experienced at some instances where there have been who are asymptomatic, in the sense they have acromegalic features, but which are picked up by their friends and relatives and so forth. They are relatively asymptomatic. They just feel that that is a normal constitution. And so in such patients, what is the what is the aim clinical cure that you're looking at? So it is just resolution of the facial dysmorphia, the tightness of the skins or occlusion and so forth. Is that cure, or is it reduction in or the better control of hypertension, diabetes, better lesser risk of malignancies and so forth? Now we have evidence to show that the risk of malignancies, renal diseases and so forth need not necessarily be linked to control of growth hormone levels. Biochemical cure does not necessarily mean that they are free of risk of malignancies, because there is a different axis which involves in the development of malignancies for these patients. So clinical cure is something which is really difficult to define in such patients. So now that leads us to the what are we doing? So that is where I appreciate what Manjul and Dhaval were talking about. How aggressive do we need to be looking at small residues in the scan, or GH levels of slightly marginally raised growth hormone levels? Should we aggressively chase all these and attempt what you call biochemical cure in all these patients? And when you look at residual tumors in the pituitary, there's always this balance of subjecting them to radiosurgery or radiotherapy, whatever it is, and then risking panhypopituitarism, which is again equally challenging problem to cure. So my philosophy of late has to be little conservative on these aspects. So achieve a reasonably good surgical eradication of the disease, And then if the patient's biochemical values are relatively within normal limits, I generally, and the residue is not too great, I'm little conservative on adjuvant therapy. And of course, although Dr. Pramila has been mentioning about the medical managements, except cabergoline, octreotide, and all becomes little challenging. Now that oral octreotide has come in, the injectables, the cost factor, and all becomes little challenging in our settings. And pegvisomant is unfortunately not available in our setting. So invariably, for most of our patients, it is a choice of surgery, then radio surgery, and maybe cabergoline. Of course, I'm not saying a lot of patients who do take octreotide, but majority becomes little difficult. So my take on is to be aggressive with surgery in the first go in symptomatic patients and follow up on the small residues. Of course, if the residue is significant, I subject them to, as Angel was highlighting, tumor-specific radiosurgery rather than pituitary-specific radiosurgery.
Thank you, Dr. Girish, for coming. Let me invite Dr. Anand.
Thank you, ma'am. And thanks to everyone for this opportunity. I think it has been a wonderful webinar covering the A to Z of growth hormone secreting adenomas. And it has been very well summarized by Dr. Girish. I would just like to re-emphasize that in this difficult situation, first and foremost, is the surgical cure seems to be the best bet if you can achieve it. And it's which is difficult in all the cases. So first chance is the best chance. So we chase secreting adenomas to achieve a good first time resection so that we get a surgical cure as possible. It's not possible because of various factors. It could be technical, it could be tumor related. We know those partially granulated infiltrations are quite resistant to everything. And once there is infiltration, there is a problem even achieving a surgical cure. So in those cases, when you find a residue and there is still lingering growth hormone excess, probably the adjuvant therapy takes over. Initially, we used to be very aggressive even on the residues, but then we have learned over time that the morbidity is quite high if you go for resurgery. The first time the residue is there, in spite of using all the best that you have, tumor is not congenial to total resection because of infiltrative disease. The firm one, three granulated ones, which have good plane and which don't have infiltration, I should be removed completely and they should not be unnecessarily subjected to other. We can have a go at it second time. First time is the best time. Of course, when they offer the best option until radio, I think medical management is the key.
Question to Dhaval. Practically, when we operate on a patient with acromegaly, the tissues are very hard to handle. They're all hypertrophied. The bone is vascular, thickened. Dhaval, do you think it is the surgical parameters in a case of acromegaly makes these lesions very challenging or dangerous for a beginner?
Sir, you need to unmute yourself.
Can you unmute? You're muted still.
Hello, can you hear me now?
Yeah, I
Yes,
can
sir.
hear.
Yeah, it's not challenging or dangerous, but it's frustrating. Like by the time you reach tumor, you would have caused a lot of mucosal damage and a lot of mucosal bleeding will occur. So it takes a pretty long time to reach sella because of mucosal hypertrophy and bleeding. So I prefer to do turbinectomy. It gives me more space. And I do turbinectomy in other cases where there is a need for extended approach. And for even for smaller tumors, in case of acromegaly, we tend to go more extracapsular rather than internal debulking. So to have a wider field of view, two-hand technique, when the turbinates are hypertrophied, it's better to do turbinectomy. That will solve most of the problems.
Can I ask Dr. Pramila something, Dr. Matthew?
Yes, please.
Yeah, please.
Dr. Pramila, no, just when again, excellent presentation. I was just wondering, why is Pegvisomant not still available in a country? I mean, that patent period and all would have been over.
Yeah. Even because I was telling you, we were part of the pesticides study for 4 years, and then we had extension for 5 years, 9 years, 7 to 8 years. We were part of the study, but they never marketed it in India. And when I asked the company that after so much of trials and giving patients and doing post studies, why you didn't market, they said it doesn't. The returns are not there. So that's probable. I think the reason of Pegvisomant is also there because they need to. These therapies are very costly. The cost of pesticide per month was expected to be 50,000. Now our patients can't even afford a 20,000, 18,000 octreotide. So where will they afford pesticidide? So I think that is the major reason most of these companies don't market some of the products. Like if you see even for our endocrinological brands like Ozempic, we got it in India after 4 years. Not for the reason that they don't have a market in India. They know that the market is abroad more for them. They get from insurance directly
No,
because
my
there the
question
insurance
was
covers it. Here
after
it
the
doesn't.
lock-in period,
Yeah.
as has happened for Ozempic, after
Yeah.
the lock-in period, won't the
Generic.
prices come down?
Generics, the lock-in period, the prices may come down, but not so much. It's only when the generics come in, then the price comes down. So that's the thing. So that's the unfortunate part, I think.
Because Pegvisomant offers the best cure rate if you look better than surgery if you look at it.
In case the size is not much of a concern because the
Yeah, of
size can
course, for the
increase. That's the
residue.
major problem.
Percentage-wise,
Yeah.
it is very good, 80%.
It can be used in combination of somatostatin receptor ligands as well. But size should not be a concern there because that's not the indication for that.
It's true.
Just a lateral question. Isn't this pesticide a choice drug for Cushing syndrome also?
We have used it. We were part of the Cushing's trial as well. And there were two ways of giving pesticides. So in Cushing's, we use the subcutaneous one, which is twice a day dose, which we give subcutaneous pesticide. That's a short-acting pesticide. And in Cushing's patients, also we used in few of our Cushing's, and there was a good response. But only problem was the hyperglycemia in one of the patients. In other two patients, they did very well. So we were part of the subcutaneous pesticide for Cushing's as well. And this for the acro, we were part of the monthly injections for pesticide or depot preparation.
So may I ask a couple of questions actually?
Yeah, please. Please,
So
Manju.
the question is to Dr. Kalra. The major problem, ma'am, happens when these acromegaly patients, you see a very small residue somewhere, and then they come with an intractable headache. This is not related to the endocrine part, but that headache is something which brings them to the OPD again and again, and then it becomes resistant. So what do you prescribe? What do you give to those patients? I earlier tried to give Nextrom, then I realized that it is a dopamine agonist, so it shouldn't be given. And then what's a therapy for them?
We should do a sleep study. Many of them have OSA. See, all these acros who are coming with intractable headache, we are doing we did some study on that, and what we found it because we didn't find any actual cause of the headache and then we did sleep studies in many of them, and we found many of them had OSA. So actually, they have OSAs, which could be also one of the. I'm not saying that's the only cause. I'm not saying that OSA is the only cause. But if you have a patient of acro who has come to you with intractable headache, and we are not finding any obvious cause, definitely we have to give medical management if the growth hormone is high. That's one. Alongside with that, we have to see if they have OSA, which is causing this intractable headache. So OSA is there in many, because acro have a lot of OSAs, most of them have. And we never do the sleep study because again, the cost factor comes into play. When we tell a sleep study, they will say, I can't afford a CPAP machine. And then the whole things go hayway. And we keep on thinking about only medical management. So we do sleep study in most of our acros. And that's what I told the indication as well. Even a pre-op case of acro, if they have severe OSA, we give octreotide pre-op because the surgical outcomes improve much better with that for the reason that this can lead to more morbidity. As Dr. Dhaval was also pointing out, CO2 retention happens and that leads to more of problems in many acros, and some of them have very severe OSA. So good thing to do is to see for the OSA component, see for their glycemic control. Hypertension is another reason for the intractable headache many times, and they are uncontrolled and they don't monitor. That also has to be seen. OSA is another thing to study. That is what we do in these patients.
Thanks, ma'am. My another question is, many times I have found a GH and IGF-1 discordance. Something is raised, another is not working. So, what's
I'll
your
tell you,
yardstick? what to
Yeah,
go
yeah,
with
that's a
it?
very
How to
important
go?
question, actually. Yeah. Very important question. See, the problem is that growth hormone has a very short half-life. It has a longer biological half-life, but the half-life of growth hormone is 25 to 30 minutes. So what happens that sometimes the in very small tumors, what happens, the growth hormone is secreted in spurts sometimes. So when you check at one random growth hormone, you can get a normal growth hormone value. But your IGF-1 is a more longer staying thing. So that is why that is why the guidelines are advocating IGF-1. Because what happens sometimes the tumor is very small and the growth hormone is secreting in spurts, and it is a half-life of 27 to 30 minutes. So you miss that spurt and you check a growth hormone, it shows normal. But when we do the IGF-1, we catch these patients. So if you have a patient whose growth hormone is normal, but the IGF-1 is still high, this clearly shows that at that small adenomas, small residual tumors, you can get like that. Second scenario, where patient is sick, very sick, the IGF-1 may be falsely low, malnourished, those patients, you may have a falsely low IGF. There you may get a better option with the growth hormone. So that's why you may have a differential response sometimes, but especially it is a problem with the growth hormone because many times they do one random level, and if the normal level the patient has hardly any tumor, we don't need to do anything. And when we do the IGF-1, it is high. And sometimes the patient will say, why are you telling us for medical management when my growth hormone is normal? So this is the reason for the growth hormone being normal, because the half-life is small, the biological half-life is longer. But what we check in the serum is the actual half-life thing. And only 25 to 30 minutes. That's the reason.
What about the combination therapy of octreotide and cabergoline?
Yeah, there is data. I did one of the studies. I did not go into the depth of it. We have some patients who don't respond to octreotide. We add the cabergoline, and we do see, especially we do see a good response in some of them. So somebody who is not getting best results with your octreotide, you can always add and see. But there is data on that. There are studies on that. Yes, definitely there are studies on that. But the only thing is the problem for us comes up because they hardly continue the octreotide unless their insurance is covering, or because we had many trials running up, so we were able to give pesticides and many things, but now those trials have come down, so we are also finding it difficult. Only our insurance patients are continuing, or those who can pay. The other patients are only taking cabergoline. They stop the octreotide most of the times. That's the problem.
Thank you.
There is a question in the chat box regarding ectopic growth hormone secreting tumors. Can any of the speakers or panelists comment on that? How should we approach ectopic GH-producing lesions?
So, okay, somebody wants to comment, it's okay. Shall I comment?
Yeah, please, madam.
So ectopic secretion can happen. See, ectopic growth hormone is very, very rare. So we normally don't think of it unless there are few indications where you are not finding the lesion in the pituitary. So this is a very rare tumor. This can only happen in few of the pancreatic and lung lesions, neuroendocrine tumors, where there can be secretion of the ectopic growth hormone. So those patients may have an ectopic growth hormone secretion where you don't find the lesion in the pituitary. And then octreotide scans, whole body scintigraphy can help to identify these type of ectopic tumors. So that can be done. But one more thing to add, like recently, I don't know if it was Dr. Dhaval's patient only. We had a patient who was having a lesion in the sphenoid, and we thought it was an ectopic pituitary which is producing. But what happened that later on we found out that when the neuroradiologist saw, they said that the sella is breached. So what actually had probably happened that the patient had a big lesion, there was apoplexy, and only that part of the lesion was left. So that was, I'm talking there in that particular anatomical area. But when we talk about ectopic, it is like neuroendocrine tumors of lung and pancreas, which can see ectopic growth hormone, which is very rare, less than 1%. We can do octreotide scans to confirm that, and the removal of the tumor is the treatment. But this is only very rare. We hardly see that actually, if you say in our clinical practice, but yes, it is a possibility.
I have a question to Dr. Girish and Dr. Anand. Practically, how often do you follow patients with IGF-1? In the long term,
all our patients we do IGF-1.
Not long-term follow-up.
Long-term follow-up, once they are cured, it's the endocrinologist who go by their protocol. Unless the IGF-1 again starts increasing, I don't even do a MRI follow-up.
Yeah, agree. First is at 3 months, Matthew, because generally it takes almost 3 months. And then if it is normal, I usually do it every 6 months. And then, of course, the patient goes back to the endocrinologist. Yeah.
Okay.
I think Manas has put another question again. managing a male and female of 30 years having residual disease and planning pregnancy. Dhaval, somebody wants to comment?
Dr. Pramila should be a better person
Yeah.
to answer this because it's not only growth hormone, fertility, and other factors also need to be considered.
Yeah, this is a very important question because recently I also had a patient of prolactinoma which is resistant. Now the patient is having this for 10 years and now wants to go for gamma knife and wants to conceive as well. Now the surgery has been done 2 times in that patient. So these are all the cases which are very difficult to decide, but we have to discuss. Now the things are two. Now if a patient is planning for a pregnancy and the growth hormone are borderline, then what we can tell there that if the surgery has already been done, we stop the medical management, we let her conceive with IVF. She may not be able to conceive like that because she won't be having ovulation. She will conceive, we give them supplementation with HCG hormones during the pregnancy. We have few patients of acro who had borderline high growth hormone, so we didn't go for a gamma knife before the pregnancy. We let them conceive with IVF. We give hormone supplementation with HCG. We have to supplement them. We have to give some hormones to continue the pregnancy because they'll be deficient with HCG because their surgery is done. So then once they deliver the child breastfeeding is stopped. Then what we do is we go for gamma knife or we restart the medical management. Other way around is if the tumor is very big and then it can be life threatening for the patient, then it's not a wise idea to tell the patient to conceive. Then we have to go for definitive management if we are planning for second surgery or we are going for gamma knife and then tell them to wait. But gamma knife will take its own time. We know that it won't be immediate. So in such cases, a second surgery with the hormone supplementation on and then IVF would be a good option. Patient has a very big lesion, then definitely it has to be first managed surgically rather than be going into pregnancy thing that can cause actually a problem and apoplexy and other things can happen. So that's not the right candidate. But borderline cases, what we do is we let them conceive with IVF, give them the hormones during the pregnancy, SCG and all, supplement, and then later on go for gamma knife. That's what we do. And then continue with the medical management.
I think we had an excellent discussion, with a lot of energetic participation. I think we have exceeded our time. I must thank all the speakers and panelists for such a wonderful session and for all the participants. Thank you very much once again. I think we can call it a day today.
Thank you.
Thank you.
Everybody.
Thank you.